Visualize Visual VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now watch our full-length documentary Open Your Eyes on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. Glaucoma is one of the leading causes of irreversible blindness, and the prevalence is increasing. Elevated intraocular pressure or eye pressure is recognized as a major risk factor for the development and progression of glaucoma, and lowering intraocular pressure or eye pressure is currently the only documented method of treating glaucoma. But until recently, experts didn't even know if lowering IOP to prevent glaucoma progression actually worked. Numerous worldwide clinical trials have been conducted to answer this question, along with the aim of improving glaucoma diagnosis and treatment. Today's guest, New York City optometrist Dr. Richard Madonna, studies and teaches clinical trial learnings to both students and practicing eye physicians. Dr. Rich Madonna currently serves as professor and chair of the Department of Clinical Education and director of the Office of Continuing Professional Education at the SUNY College of Optometry. Dr. Madonna is well published and has co-authored many books and chapters. Clinically, his practice at the University Eye Center is limited to glaucoma. Dr. Madonna, thank you for joining me today.
Thank you, Dr. Gelb. It's a pleasure. I really appreciate the invitation.
You know, we've known each other for many years. We've been friends for many years. And, you know, this topic of understanding studies, clinical studies relating to glaucoma has been a topic I've been fascinated with for many, many years. Tell me, why are clinical trials important?
Yeah, I think there's probably 2 main reasons. Number one, it provides us with the evidence base we need so that we know that our management decisions are based in fact and not in, anecdote or fiction and so forth. But I think, and you touched on this a little bit, one of the other important reasons is if we go back to the late 80s, let's say, when we didn't have these large-scale randomized clinical trials in glaucoma available to us, insurers started to ask the question, well, we're paying you to do all of these tests to study whether glaucoma is present or whether it's progressing, yet we don't have any real good evidence that what you're doing to treat glaucoma actually does something, even though we've used medicine to lower pressure, and then at that point in time, lasers to lower pressure for a long period of time. We still didn't have that great evidence to tell us that it was actually useful. So that's where many of these clinical trials that showed the utility of lowering intraocular pressure was actually useful became really handy to say to insurers, yeah, what we're doing makes sense, and we really do have to do this testing. So I always ask the question, what if the answer was actually no, and it didn't show that lowering pressure meant anything? Then everything would be a crapshoot, and we wouldn't be doing the testing that we do or the treatment that we do. So really important stuff.
It's really interesting, because if it would have came out that lowering intraocular pressure didn't work, we would have had almost 100 years of treatment that we've been doing that would have been worthless.
All that pilocarpine would have been used for nothing. So yeah.
And I think before we go over the clinical trials, I think it's important to note that a lot of the clinical trials were done before OCT and some of the newer medications that we use. But in a way, it's not really the point, because the point is we want to know if lowering pressure in a lot of these trials worked.
Yeah, I think the big thing with no OCT is more sensitive than certainly in eyeballing optic nerves, even stereoscopically. OCT is going to be more sensitive in detecting progression. So when we look at progression rates in some of the studies, we might anticipate that the progression rates would have been higher if OCT were available. That said, when we're looking at quality of life relationships in glaucoma, we're really often looking at visual fields. And that hasn't really changed all that much in the last number of years. I know when we worked together back at SUNY, we were doing a lot of Goldman fields, or we were around in the early days of Humphrey visual field analyzers, where we had no statistical analysis, where it was kind of a crapshoot trying to determine actually what we were looking at rather. So, that's where we stand right now, but I think your point is well taken about OCTs.
I remember when we used to do Goldman fields, whoever got the short straw had to go and do the Goldman fields.
Spend the morning looking into the tube and listening to it dinging buttons and so forth. Probably half the practitioners out there don't even know what we're talking about, but that's
it's a long time ago. So let's start with the first and one of the most important clinical trials out of Washington University, St. Louis, conceived in the 1990 by Dr. Michael Cass and his team, the Ocular Hypertensive Treatment Study. And it really wanted to know, first we want to know before we go into it, we want to define ocular hypertension. And and the goal of the trial really does lowering eye pressure prevent glaucoma. If someone has eye pressure, but they don't have damage, does it prevent glaucoma? So tell us what ocular hypertension is.
Yeah, by definition, I think most clinicians would agree, ocular hypertension is eye pressure greater than 2 standard deviations from the mean, which is greater than 21, without sign of structural or functional change consistent with glaucoma. So in other words, no damage, yet high pressure.
And this is a very interesting study because it went on for 20 years. How often do we see studies that went on for 20 years?
Absolutely true. The 20-year OATS came out within the last couple of years. I don't think it's really penetrated very well into, as we know, studies take numerous years before practitioners actually recognize the results. So I think there's very low penetrance of this study so far, of the 20-year study so far.
So what do we look at in the study? Who was incorporated in the study? What was the pressure and what tests were done?
Sure. So the study was aimed at ocular hypertensives as defined in the study of pressures between 21 and 32 in one eye, and I'm drawing a blank on the other eye.
24 and 32 in one
24
eye.
and 32 in the other eye. I've talked about this about 1,000 times.
Right.
So anyway, high pressures, no glaucoma damage as detected by the people in the reading center. So in other words, we had actual bodies looking at stereoscopic optic nerves and assessing whether they were normal or glaucomatous, and looking at visual fields and assessing whether they were normal or glaucomatous. So based on the expert readers, there was no damage, yet the patient had pressures, as we said, between 24 and 32 in one and 21 and 32.
So to understand the studies, you have to understand a little bit about visual fields. So if it's okay, if you could share your screen and just review the important parts of the visual field for our audience. Now, some of our audience,
get this done.
Yeah, take your time. Some of the audience is from the vision community, but we also have some people from the public. A lot of the public watch this, and after we release this in the first week or two, we'll have between 20 and maybe 40,000 people watching this.
Right.
So a lot of people are going to watch this. So so if you could go over this and just give us a lesson on understanding how to interpret a visual field.
Sure. The first thing I do, of course, is make sure I've got the right patient and it's blocked out here. And, you know, that sounds obvious, and then make sure that I have the right test. So I'm doing a Central 24-2. Can you see my mouse?
Oh, yes, I can.
Okay, so Central 24-2 visual field. Next, I want to check to the reliability indices. So we see here that there were no fixation losses in 16 checks. I want to check for false positives. In other words, the happy clicker, somebody who's clicking when there's no light there, which is probably the best detector of reliability, and look for false negatives. So in other words, a light is presented when at a point, a very bright light is presented at a point that's already been shown. The patient has already shown that they can detect light at that point. So that would be a false negative. I also look at the gaze tracker here, which is looking at excursions of the eyes without going into all the details. Quickly here, we have the absolute values of each of the points. So for instance, this point here is at 27 decibels. Remember, these are decibels. And I look at the grayscale. Some people say don't look at the grayscale. I think the grayscale is useful. Just a quick look at this one tells me this patient has a relatively big blind spot. We expect that the field will get a little bit darker toward the periphery because the points in the periphery are less sensitive than those centrally. So there's a little less sensitivity here superiorly, which could be trial frame, could be lid, or it could be real. And the same thing here in this nasal area, which of course is an important area for glaucoma. I also like to look in this region, which a couple of things here. The glaucoma hemifield test, if I backtrack for a second, I always want to ask myself the question, why am I doing this visual field? Is it to detect glaucoma or to look for glaucoma progression? If we're looking at glaucoma detection, we really want to know, we want to separate normal from abnormal. And we know if there's one single index on this visual field that best separates normals from abnormals, it's the glaucoma hemifield test. If we remember that glaucoma is an asymmetric, a relatively asymmetric disease, meaning it's asymmetric. It starts in one eye before the other eye, and it also starts one hemifield before the other hemifield. So the glaucoma hemifield test compares clusters in the superior hemifield versus those in the inferior hemifield. And then it uses an algorithm, and if it goes beyond the threshold of that algorithm, then you'll get a message that says outside normal limits, or it'll say normal, or it'll say reduced sensitivity, or it'll say borderline. So this is an outside normal limits field, which would make me sit up and take notice that there's a significant difference between the superior and inferior hemifields. By the way, I just realized I'm looking to the side because I have two screens. I'm not looking directly at the camera.
Oh, you're doing fine.
But I'll come back. The VFI is a proprietary index from Humphrey, and this is a Humphrey field analyzer field. Obviously, there are others. And this is a proprietary index that puts a single number from 0 to 100 based on the sensitivity of the field. And I'll just leave it at that. The mean deviation is the average deviation of each of the points from as compared to the reference database, and the pattern standard deviation is the average deviation of each of the individual points. So it's the standard deviation of each point as compared to the baseline. Finally, if we look here at the total deviation is comparing each of the individual points to baseline. So if you look here at this one, I think it says -3. So that point as compared to the age-matched reference database is 3 dBs less sensitive than expected. And then the pattern deviation takes into account the height of the hill of vision. So this hill of vision is depressed, the mean deviation is -6. So it kind of takes that into account and boosts the hill of vision, looking for patterns of loss within the visual field. And we could see that we have a cluster of points here, here, and here. And many of these points have been eliminated because the hill of vision was boosted to look for greater patterns of loss within the visual field. So that's kind of my quick and dirty overview of looking at an individual visual field test.
Just a quick question on a lot of these studies, they use mean deviation and pattern standard deviation in the studies.
Right.
So mean deviation, what would you say in the normal range, or pattern deviation, what would you say is in the
theoretically it's 0, because everything else is a deviation. It can be plus. Those of us who do a lot of glaucoma, and probably most people in practice, because they're only doing fields on patients who might be at risk, the mean deviation is also a minus number, because it's less sensitive than expected. But of course, there are people out there who are more sensitive than expected. We're just not typically doing those patients or doing visual fields on those patients. But in glaucoma, if we look at mean deviation as a metric, typically milder early glaucoma is often defined as a mean deviation between 0 and -6. Intermediate glaucoma or moderate glaucoma between -6 and -12, and then severe or advanced glaucoma greater than -12. So, it's sometimes difficult to use MD as a metric because, plenty of normals might be -1. Additionally, media opacities will lower the mean deviation. So, somebody can have no glaucoma, but a cataract and might have a mean deviation of -4. Doesn't mean they have glaucoma. The pattern standard deviation may be more useful in some sense because we're taking that hill of vision drop into account and removing it, and therefore looking for patterns of loss that might be more consistent with glaucoma. You'll notice there's no plus or minus on the pattern standard deviation. It's just a number because it is a standard deviation from the reference database at each individual point.
And you use a number of around 2, up to 2 as being normal, or
on the pattern deviation?
Yeah, on the pattern.
Actually, I tend to look at p-values. So you can see here, the p-value is less than 0.5, telling me that only 1 in 200 normals will have a pattern standard deviation of that number. So that's what I tend to look at more than the absolute number. Back in the day when you and I first started and we had standard fluctuation as part of the numbers, then we had to do a lot of the calculations ourselves. Like we sometimes used to say, if the standard fluctuation was 3, then a point that was depressed by 6 might be a useful. I think, one thing we would do is double the fluctuation. We don't have to do that anymore because we have lots of reference databases available to us.
Well, I appreciate that. All right, let's get back to the study.
So let me stop my share.
And
sure that's out of the way.
And I really thank you for that, because that kind of sets up the clinical trials.
Let me get that off my screen just to make sure. You know what? Yeah, get that out of there. Okay, and let me just do one other thing with my screen. Good. I think I'm good to go.
Beautiful.
All right.
So let's look at the risk factors for, according to the OHTS study, for primary open-angle glaucoma. What were some of the risk factors that they found?
Yeah. So just to backtrack, what the study did was look to determine whether to compare treatment to lower IOP versus no treatment, and compare the differences between the two, and essentially showed that treatment did lower the risk of progression to glaucoma in one eye over 4 years. So not unexpectedly, lowering the pressure reduced the risk. But I think another important point is, although 9.5% of the patients who were treated I'm sorry, 4.4% of the patients who were treated developed glaucoma over 5 years. 9.5% of the untreated patients went on. So 91.5% did not go on to develop glaucoma over 4 years. I might have messed up the math a little bit, but I think the important concept to remember is a lot of patients who were treated didn't go on to develop glaucoma, but a lot of patients who were untreated didn't go on to develop glaucoma. That's what I really wanted to say.
Yeah, and I think it's 4.4% of the treatment group. Of the treatment group went on to develop glaucoma, because in this study, the average lowering of the pressure was about 22%.
Right, 22% or so.
So the treatment group still some 4% or close to 4.5%.
Not surprising.
Progressed.
Yeah.
And close 9.5 or close to 10% didn't progress. So then it begs the question, maybe we didn't lower the pressure enough.
That's a possibility, because the only thing they were looking for was to lower the pressure by 20% or to get it less than 24. So it is possible that it's likely more aggressive treatment would reduce the risk of progression, but at what cost? Side effect cost, monetary cost, patient adherence cost. So it was not an aggressive treatment, but probably makes sense to not treat aggressively in a group of patients who don't have obvious glaucoma.
And as we go through, ages will help answer some of those questions.
Yep.
So, but sticking with this, so we learned some other things in this study. One was central corneal thickness.
Everybody bought pachymeters after the OHTS was published in 2002. So I think what really came out of OHTS, besides what we already said, the treatment versus the no treatment, was that there were some risk factors that were incredibly important in predicting who is most at risk for glaucoma development. And this is where central corneal thickness really came into play. Before 2002, not many people had pachymeters unless they were using them for contact lenses and things like that. But we found that central corneal thickness, and more specifically thinner central corneas, were more highly associated with the development of glaucoma. For every 40 micron thinning of central corneal thickness, there was a 71% increase in the risk of developing glaucoma. Another comment about central corneal thickness and hypertension, ocular hypertension, that's extremely important, is to remember that although we know that the average central corneal thickness is 545 microns on ultrasonic pachymetry, but in the OHTS study, the average central corneal thickness was in the 570s. So in this cohort of patients, it wasn't for 545. It was, let's say, 575, just for the sake of argument. And that's important to remember. So when you see an ocular hypertensive patient who has an average corneal thickness of, let's say, 545, that's actually a thin cornea for ocular hypertensives. And those patients are actually in the highest risk tertile of patients. When they looked at these, they divided the patients into 3 tertiles of patients: less than 555, more than 588, and then those in the middle. So people with average corneas were actually in the highest risk group, the thinnest of the corneas. Very important to remember that.
And I think one of the things from the trial, if the pachymetry was, the corneal thickness was less than 555, but the pressure was over 26,
we're out.
There was an over 35% chance of getting glaucoma.
And that's dead on. And additionally, remember, it's not a continuous variable. So the 550 people are in that group and the 500 are in that group, but those with 500 are way higher than a risk of 36%. So if you have a pressure of 30, let's say, and a corneal thickness of 510, you're at very high risk of developing glaucoma in the next 5 years, and at least one eye, which is what the OHTS looked at.
And if you look at the 10-year, if you look at the 10-year data, the treatment group started to progress, and that's kind of upsetting in a way.
Well, both groups progressed. What the 10-year data was in, why the 10-year data was important was because they asked the question: is there a penalty for not treating patients? So we knew that after 5 years, there was this difference between the treatment group and the untreatment group, 9.9 versus 4.4, 9.5 versus 4.4%. We knew that. So the question was, at 10 years, did the group who weren't treated get penalized for not being treated? So what they did was, at about 7 years, just about everybody in the treatment group was treated. And they showed that at 10 years, the slope of progression for both the treatment group and the non-treatment group were exactly the same. So if you say, I'm going to watch this patient, let's say you watch them for 7 years and you say, you know what, I better start treatment on them. It looks like they might be progressing. And you start treatment, then their risk of continuous progression is about the same as if you had started treating them from the beginning. So that was heartening, because then we realized that, okay, if we delay treatment and then start treatment, we would not be penalized by having a greater risk of progression later on. That's what was important about OATS 2, which was 10-year-olds. And the second thing, if I can continue about OATS 2, that was exceedingly important was, if we stratified our risk into low risk, meaning less than about 5% or so, high risk greater than about 15% or so, and those in the middle. And that risk stratification was based upon the 5 major risk factors: central corneal thickness, intraocular pressure, age, pattern standard deviation, or loss variance if you're using an octopus, and vertical cup to disc ratio. You can stratify risk by percentage, and you can do that using a risk calculator. The patients in the lowest risk group, less than 5 or actually 6% in the study, there was essentially no benefit of treating those patients. And that's crucial, because if you look at the patient who has a pressure of, let's just pick 28, thinking back to the days when we started, 28, we'd really sit up and take notice. But if that patient with 28 has a corneal thickness, let's say, of 600, and has a pattern deviation of, 1.4, and they're 70 years old, or let's say 50 years old, their risk is extremely low. And OATS 2 told us that treating those patients does nothing. We're probably treating ourselves. We're making ourselves more comfortable with that 28 pressure than doing anything for the patient. And I think that's critical. So when OATS came out, I found myself taking almost as many patients, at least ocular hypertensive patients, off medicine than I was putting on medicine, because I think they were overtreated.
And how about the 20-year data for OATS 3?
Yeah, so the 20-year data is interesting. So the 20-year data came out at the end of 2020. And I think it told us sort of the same lessons. So some of the things we learned from the 20-year data was the rate of progression to glaucoma in both the treatment and non-treatment group actually accelerated a little bit, so that the slope of the line went up in both groups, although there was still a clear separation between treatment group and medical group. So that's important to remember. As patients get older and time goes by, we have to take that into account. In fact, if we look at all comers, all ages, African Americans, and just look at everybody, more than 40% of the patients from the original OATS cohort who are still alive went on to develop glaucoma. So that's important to remember. But only 25% of them had field loss. So only 25% of the patients actually showed field loss. Most of them showed changes in their optic nerves. So that's important, because what are we really trying to do in managing glaucoma? We're looking to prevent loss of vision-related quality of life. And although we can look at studies where even in patients who don't have visual field loss, there's probably changes in glaucoma patients in, driving and motor vehicle accidents and reflexes and a number of other things. But if we just look at visual field loss, the majority of patients didn't develop field loss. The other thing that came out of OHTS-3 is, again, if we look at solely at that low risk group, again, we don't, and for the most part, don't need to treat those patients. And in fact, they're just about more, the patients in the original cohort were probably more apt to die than to develop visual field loss in that very low risk group. So to me, the take home is, let's identify who is high risk and who is low risk. The high risk group, I think you want to treat them and perhaps treat them more aggressively than in OATS, as you mentioned before. The flip side is the low risk group probably doesn't deserve treatment and only deserves watchful waiting. And if they're one of the few in that group that do develop progressive type glaucoma or progression to glaucoma, then treat them accordingly. And the ones in the middle, you have the conversation. So I think OHTS-3 adds to that.
And who are the high risk? Who's in the high risk group?
So the high risk group would be the people with higher pressures, thinner central corneas, higher pattern standard deviation to start with, and larger cup to disc ratio. So some people may say, well, they may have had early glaucoma even at the beginning of the trial, and then older patients. But the flip side of that is, and this is one of those things you have to think about when you think about ocular hypertensives, whereas the older patient is more apt to progress, they're also more apt to live fewer years. So it's actually sometimes the younger patient who is, at least according to the risk calculator, less apt to progress. You may treat them because we know that time will increase their risk of actually going on to develop glaucoma. So that's where the art becomes more important. That's, that's where the thinking clinician comes in.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
The All Eyes Visual VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information. So the risk calculator, is that something that you still use, and are you teaching the students the risk calculator?
Yeah, I think we do, but the risk calculator is available online. You just put in Washington University risk calculator, OATS calculator, and it comes up, and it's an app. I think you do have to pay for it now, but it's $1.99, I think, maybe the last time I looked. And all it is it's a calculator where you put in the 5 major risk factors, and it tells you the risk of the patient developing glaucoma in the next 5 years. So that just allows me to stratify the patient's risk. I'm not going to use that as a be-all and end-all, but I think it does help me put the patient in one of the categories. And I know I always mention it to my students because I think it does have utility, and it has utility with the patient as well. Mrs. Jones, you were in the lowest risk group, although your pressure's high. And, I know your husband has glaucoma because he had high pressures. I don't think you need to be treated because you were in this low risk group. Or the flip side, you're in the high risk group, and although we don't see any glaucoma damage, I think it behooves you to be treated.
Do you think there's a problem with the risk calculator because it doesn't include OCT?
Great question, because it does not. And so I think if, as we briefly mentioned before, I think if we utilized OCT in any of these studies, OCT is more sensitive, so more patients are going to be identified as having glaucoma. Now, some of them would probably be identified before the beginning of the study, so they wouldn't even have entry into the study. But the flip side is those that were normal at the beginning would be more apt to be detected earlier in the study. So we may pick up more patients that way, and these numbers would be skewed higher. So OHTS-3, although not published yet, did include OCT in the later parts of the study. So we'll see what that tells us when that data becomes available.
And how did they include OCT?
I'm not 100% sure how they did it.
So there's some ancillary studies with photography was used, and something we call Drans hemorrhages or disc hemorrhages.
Yep.
Can you elaborate on that a little bit, how that could be helpful?
Yeah, advanced hemorrhages we know are exceedingly important in detecting progression. You know, if you get a Drance hemorrhage, it's an increased risk of progression. You get 2 Drance hemorrhages, you know, the risk goes up. It's kind of like herpes simplex, if you will, keratitis, where, you know, 1 recurrence leads to greater recurrences and so forth. So we know that if we have the presence of Drance hemorrhage, then we know that there is a greater risk of progression. Good way to think of it is Drance hemorrhages are excellent signs of past, present, or future progression. That's always the way I think about Drance hemorrhages. And not surprisingly, in the OATS study, it was shown that Drance hemorrhages were useful in detecting patients who would progress. I'm trying to think if there was anything else. Oh, and the other one was the
photography. How good at doctors, which is better, photographs or the doctor at detecting changes in the optic nerve?
Yeah, you know,
hemorrhages.
Looking at stereoscopic disc photos is, in terms of disc hemorrhages, there's no question that photography is the most sensitive way to find them. Yeah, and I'm glad you brought up that point, because, you know, we're seeing many fewer photographs being taken these days because of the advent of OCT. But I think it behooves us to periodically, at least, take disc photos, because it's much more, disc photos are much more sensitive in detecting Drance hemorrhages than our ophthalmoscopic view. That said, if we're not taking photos, I still always want to look at the optic nerve at each visit, because even though my sensitivity may not be great at detecting Drance hemorrhages, but there is a sensitivity there, and I may detect a Drance hemorrhage, which might have been missed if I didn't look, or would have been missed if I didn't look.
And I just want to bring up that the European Glaucoma Protection Study agreed with the OATS study for finding the same risk factors.
For the risk factors, not necessarily the results of the study itself. It's kind of interesting. They used dorzolamide, and there was a reduction in pressure with dorzolamide, but there was also a fairly substantive reduction in pressure with placebo. So some of the results are a little different in terms of reducing risk of glaucoma, but in those patients who did progress, the risk factors were the same. And in fact, if you look at the risk calculators, it really comes from OATS and the European Glaucoma Prevention Study. So I'm glad you brought that up.
So as we move on to the early manifest glaucoma trial out of Sweden, before we do, just give us the bottom line from the OATS. We have 5-year, 10-year, 20-year data. What's the bottom line that people should remember?
Yeah, my take home from OATS is to stratify risk according to the 5 major risk factors identified in OATS: central corneal thickness, age, pattern standard deviation, vertical cup to disc ratio, and intraocular pressure. And you can best stratify risk by using a risk calculator and try to identify which patients go into the low risk, medium risk, and high risk group. More than likely, you will treat the high risk group even in the absence of glaucoma damage. You should follow the people in the low risk group, and in the moderate risk group, you kind of work with the patient. So that to me is the biggest take home from OATS. I think that kind of summarizes the whole thing in one package.
Well, thank you for that. So let's talk about the study out of Sweden, the early manifest glaucoma trial, where they actually wanted to see if someone is diagnosed with glaucoma and whether or not treatment or no treatment worked. So you have glaucoma and you're in the non-treatment group. This is an interesting study. Give us some of the background on this.
Yeah, well, you said one of the most important parts of it is it was done in Sweden. It's a National Eye Institute study, but the study group was in Sweden, because in Sweden they allowed there to be a group of patients with manifest glaucoma, identified as having glaucoma damage, but not treated. We were not able to do that in the United States. So you can think about that one any way that you want. But it's an interesting study because it came out of a very, very large pool of patients in community glaucoma screening, many thousands of patients. But after inclusion, exclusion criteria, ended up with, I think, about 255 patients. Is that the number? But half of those patients were identified as having glaucoma, but not treated. And the beauty of that is that you then got natural history information. So you were able to follow patients without treatment and said, what does glaucoma really do here? And I think that was a genius in some ways to have that group. Obviously, there was a lot of scare regarding taking a group of patients and saying they have glaucoma, but not treating. But that, I think, really made this such an incredibly valuable study.
And it was pretty equal amount of people, 129.
Yeah, 129 versus 126.
126.
Yeah, so essentially the same number in each group.
And every 3 months, they would examine these people and look at the optic nerve. They would do optic nerve photos and a 30-2 visual field.
Again, no OCT.
No OCT. And they followed them for 4 years. And who was included in the study? So excluded and included.
Yeah, so the inclusion criteria, all the patients were between 50 and 80 years of age. So that's the hot time for glaucoma. And they had to have repeatable visual field defects to be in the study. So that was important. So they had to show that they truly had glaucoma.
And I thought it was interesting because they had open angle, pseudoexfoliation, and I believe normal tension. Is that right? Normal tension.
It's really important. So you're running kind of the gamut of open angle patients, including, as we know and the studies show, really the most risky open angle glaucoma patients are those with exfoliative glaucoma. And if you remember, Sweden is an area where exfoliative glaucoma is hyperendemic, if you will. So those patients were also in the study, and they were in some ways outliers because it's such an aggressive glaucoma, and that came through nicely in the study. The exclusion criteria were essentially people who had bad stuff. The pressures were high. They had lots of field loss or threatening fixation. They had other causes of field loss. So those patients were excluded from the study. Not surprising.
And they wanted to get the pressure lowered by about 25%. And what medication or procedures did they use to get it to 25% in the study?
Yeah, we should backtrack for a second. In the OHTS study, they had a target pressure. The target pressure, which we said before, was a 20% reduction in pressure and a pressure less than 24. And you can get there any way you wanted. When OHTS started, there were no prostaglandins, so most patients were on beta blockers. And then when prostaglandins came out, they were on prostaglandins. In the EMGT, they weren't worried about the target pressure. Everybody got the same treatment. And that's one of the criticisms of the study, because everybody got 360-degree ALT plus betaxolol twice a day. When was the last time you prescribed betaxolol?
25 years ago.
Yeah, probably right around then. So everybody got the same treatment. So the downside of that is that's a treatment probably nobody gets. The upside of that was we didn't look at a target pressure. We looked at how effective that treatment might be. And, we looked at the average lowering and then looked at progression in that overall pool of patients who were treated. So it's a different approach than the OHTS study where there was an actual target pressure.
If you could explain ALT just for the people watching.
If we think about laser trabeculoplasty, which is the use of laser energy to increase trabecular outflow, that's essentially what laser trabeculoplasty does. So ALT is argon laser trabeculoplasty. As you know, argon laser is a heat-based laser. So essentially, you're using heat to cause change in the trabecular meshwork. So the advantages of ALT was that, you get remodeling of the meshwork, which increased outflow. The downside was you actually got heat-based damage in the meshwork, which probably reduces the ability to repeat ALT. So in the late 90s, SLT, selective laser trabeculoplasty, started to become part of our treatment paradigm. And in SLT, we use larger spots of lower energy, so there's less damage to the trabecular meshwork, theoretically increasing our ability to reutilize the test. So on first treatment, ALT versus SLT is probably pretty similar IOP lowering, but SLT probably allows us to repeat the test more. I think that's fairly clear. Or even in patients who failed ALT, I think, no, I don't think, I'm sure that using SLT in those patients is better than repeating ALT. So at this point in time, very little ALT being done. SLT and derivatives of SLT have now become the treatment of choice in trabecular meshwork-based laser treatments.
And for progression, what would they consider progression of perimetry or disc changes?
Yeah, so that, they were looking at repeatable changes on visual field, or based upon the examiners, the examiners agreeing that there was change. And you can think about the subjectivity that goes into looking at optic nerves. They used flicker chronoscopy, so it's flicker looking at optic nerves, and then they were confirmed on 2 consecutive visits. So they took some of the variability out, but making sure that 2 consecutive visits, there was an agreement that there was change in the disc. And on the visual, actually the visual field and parametric criteria was interesting, and it brings up another interesting point. There had to be 3 points on a visual field that were flagged 3 consecutive times to be considered progression. Now, those of you who have Humphrey software might say to yourself, oh, wait, that sounds familiar. The glaucoma progression analysis. On the glaucoma progression analysis, you get the flag likely progression when 3 points are flagged 3 or more consecutive times. So how did that happen? Well, Anders Hale, who is the first author on much of the EMGT, certainly the top clinician on EMGT, is also a big consultant for Zeiss. Now, it doesn't mean we can't use other fields for this, but this was done with the Humphrey Field Analyzer. So the glaucoma progression analysis on your Humphrey software came directly out of the EMGT. And as we had one other piece, because it leads into some of these interesting discussions, it's a very sensitive look at detection of progression. Why would they want a very sensitive progression detector? Because they had half their patients were patients diagnosed with glaucoma who weren't being treated. So they wanted real sensitive glaucoma detection, as opposed to OHTS, which was the other way around. They didn't need it to be so sensitive because the patients didn't even have any manifest glaucoma. These were manifest glaucoma patients. So interesting approach.
And once they saw progression, I assume they would treat them.
They would treat them, right, in the control group, they would treat them, and in the treatment group, they would treat them more aggressive. Yes.
So the treatment was reduced by about 25%. So when they compared who got treated versus who didn't get treated, what were the results?
Yeah, so to backtrack a little on that, not surprisingly, and anybody who manages a lot of glaucoma, although we think about glaucoma and everybody's thinking pressures 28, 29, 30, that's not the way it works. If you do a lot of glaucoma, that's not where the pressures usually are. And in the EMGT, the average start pressure is, let me just make sure I'm giving you the right number, was 20.7. 20.7. So a lot of these patients did not have high pressures. which is kind of interesting. You know, a lot of these patients, the patients in the study, mostly had early glaucoma because the bad ones were excluded from the study. So you're starting with relatively lower pressures, and the treatment, ALT plus pataxolol twice a day, lowered the pressure about 25%. So in the treatment group, you get about a 25% loss from an average start pressure of, you know, let's say around 21. And then the results are kind of interesting because remember, we're using a very sensitive progression detector, 3 points only, repeated 3 times. And what we found was that the treatment group had over 6 years, 43% of those patients progressed. So fairly high number. And in the no treatment group, so again, manifest glaucoma, no treatment, 62% progressed over 6 years. So 19% difference. But additionally, treatment reduced, or rather increased the time to progression. So in other words, it took longer for a patient to progress. So there's certainly a clear-cut treatment benefit and not surprising, again, going back to our original premise here, it would be a horror show if it was the other way around, you know, that treatment wasn't shown to be beneficial. Another thing that they showed was each millimeter of pressure reduction reduced the risk of progression by about 10%. Now, that doesn't mean that if you reduce it 10, you're going to get 100% risk reduction. It doesn't work that way. But in this group, in that, you know, kind of 5 millimeter, because that's all it was, 20 to 15, each millimeter reduced the risk by about 10%.
You know, looking at this trial, 43% of the treated people still progressed that had laser. They had laser or they had eye drops. And that is a sobering number.
It is a sobering number, but we also remember it was a very sensitive, the glaucoma progression analysis, as it's now known, and what they used in the study is very sensitive. It's only 3 points. They don't have to be a cluster of points. They could be any 3 points within the 54 points in the visual field. So it's a sensitive detection of progression. So it's not surprising that the progression number is relatively high. But yes, it is sobering.
The bottom line of this study, what do you feel the bottom line is?
Yeah, there's lots of bottom lines to this study. Lowering IOP helps, and every millimeter of pressure, at least in that, you know, that 20 to 15 range, each millimeter seems to be associated with about a 10% risk reduction.
So exfoliation.
Okay. Yeah.
Go ahead.
The natural history part, which we haven't gotten at too much, exceedingly important in this, because in the natural history part of the study, what we did see is that in the control group, the untreated group, the average, and this is an average, the median was a little bit different, but the averages are ones that stick with me. The average patient in the untreated control group progressed at about a rate of 1 decibel per year. This is untreated control group, about 1 decibel per year. And if you think about the dynamic range of the visual field, you know, being, you know, 35 dBs or so, that kind of makes you feel reasonably good. Most of these patients had small amounts of field loss when we start. The normotensive group within that pool of 126 patients only progressed at about 1/3 of a decibel per year. And that's consistent with the collaborative normotension glaucoma study, which was another trial that actually came out before the EMGT. The high tension group progressed at about 1 1/3 decibels per year. But the exfoliative group progressed at about 3 decibels per year. And many of the exfoliated patients were excluded from the study because their pressures were so high or they had so much damage to start with. So it again brings home the fact, identify exfoliation early on and treat those patients incredibly aggressively and stay on top of them, because it's a blinding disease. And that was an indirect outcome that came out of this study.
And one of the reasons why it's so important to dilate patients is
Absolutely.
exfoliation disease.
Very hard to find exfoliation. I mean, you can, if you look very carefully at the pupillary rough or see pigmentary changes on gonioscopy, but yeah, you can see it best through a dilated pupil and looking at the surface of the lens. So that was very important. Other things that came out of the EMGT that we haven't mentioned, they did look at central corneal thickness, and that was shown just as with OATS, but that was important. And they also looked at blood pressure in these patients, and they found that lower blood pressure was an important risk factor for the development of glaucoma, particularly in the patients with lower intraocular pressure. So that hypotension is important in that particular group. And we've seen that across a number of other studies. That's really important. Actually, it was interesting that systemic hypertension was actually protected in the group of untreated control group.
And the reason why?
Probably perfusion to the optic nerve is what we think. But perfusion is really a complicated matter. We've dumbed it down necessarily to blood pressure minus intraocular pressure as regulated by autoregulation. It's probably much more complicated than that, but it is useful to be able to identify that.
Well, I thank you for that. Let's move on to the next one, where we're looking to see about normal tension glaucoma.
Yeah.
Collaborative normal tension glaucoma study, 1998, was started to answer if IOP was not involved in normal tension glaucoma. Because at one time we didn't know if people with normal or low tension glaucoma, some people call it, was lowering IOP helpful. So if you could give us some background on this very important.
Yeah, I mean, you said it well. That's the background. Does IOP matter? We got more sophisticated in the late 80s and 90s and starting to really recognize that there's much more to glaucoma than just high intraocular pressure. We know there's a subset of patients who have normal pressures. Whether that's actually a different disease or not is probably even another question that's being debated, or is it just open angle glaucoma with low pressures? But the question really was, does IOP even matter in this group of patients? And so in the collaborative normal tension glaucoma study, that's what we looked at. The evaluation was, what's the role of IOP control in preventing progression? That was really the question being asked in the collaborative study.
And in the study, there was nobody with pressure over 24.
Right, and that's one of the criticisms of the study, because 24 is a little higher than what we think of as normal tension, but that was it. You're absolutely right.
Right, we would maybe like to see it around 18 or lower.
Yeah, at least less than 21, so up to 24, those patients were in the study. So that was kind of a little bit different.
And how were they treated?
Yeah, so the treatment, I just want to pull up my slides so I don't miss.
No, take your time.
Yeah. Where's my treatment? Collaborative study. I just want to make sure I've got everything on it. But the treatment was essentially could include surgery, and many of the patients had surgery. So there was aggressive treatment in patients who showed progression. They were treated aggressively. So that's not typical. But I think the biggest thing that comes out of the collaborative study was, again, there was a untreated control. And I think that's another beauty of this particular study, is that we had some patients that were not treated. And I think it's very important because it told us that in the untreated control group, even in that group, at 7 years, only about 50% of them progressed. So it makes me feel better about taking care of normal tensive patients who maybe I can just follow them even without treatment.
And this study, the goal was to lower the pressure 30%.
Right.
And they use either meds, ALP, or filter, or TRAB, or a combination of.
Get it down 30%.
Right.
And, for those of us who manage glaucoma, when you think of a patient, let's say with a pressure of 18, getting it down 30% is a lot of work. 30% is what, 5.4 off of 18. So to get a patient from 18 down to 12 or 13 is usually going to take at least, certainly more than one medication most times. So this was relatively aggressive treatment in the treatment group. And
the non-treated progressed at 35%, which I thought that was a pretty good progression.
Yeah, in 35% at 5 years, I believe, and 50% at 7 years. But the flip side of that is, considering you're not treating them, it's not so terrible. And these are patients with low pressures. And we know from the EMGT that people with normal tension glaucoma tend to progress slowly. I think further evidence since then tells us that some of these patients, we actually knew that then, that some of these patients have field loss close to fixation. So we do have to be careful with those patients. Even though they may be progressing slowly on mean deviation, they may have focal defects close to fixation. So we do have to be careful with that. The other thing about IOP lowering in that particular study was that the benefit of IOP lowering was not clearly shown unless you factored out cataract, because many of these patients had trabeculectomy, and what's one of the adverse side effects for trabeculectomy is the development of cataract. So a lot of these patients had TRABs, so a lot of these patients had cataracts. What do cataracts do to visual fields? They affect visual fields. So unless you factored out the cataract, there wasn't a beneficial effect of IOP lowering. Now, if you did factor out the cataract, then there was a benefit, but the patient in real life had a cataract. So you had to do something with that to gain the benefit of IOP lowering in slowing down the progression of visual field loss. So that's important to remember. The other thing to remember besides slow progression in these patients is that not surprisingly, there was individual variation in the response to treatment or in the risk of progression, and that certain subsets of patients were more apt to progress. And who were they? Females. And my experience, the great majority of my patients are female. But certainly when I look at normal intensive patients, definitely a large number of those patients are female. A history of migraine. So we know that there's vasospastic phenomena in migraine, and females get migraines more than males. So those things go hand in hand. And optic disc hemorrhages. Patients with optic disc hemorrhages were also more apt to progress. So it told us to look very carefully at certain subsets of patients. And a lot of that came out of the EMGT as well. So there's some overlap between those two. So I love those two studies together because of the untreated control group, particularly telling us, to look carefully and individualize our care, and also recognize that normal intensive glaucoma, even untreated, progresses slowly. But again, identify which patients are at greater risk. One thing that I think all the studies tell us is identify and individualize your care of patients.
So the bottom line of this study is?
Yeah, I think, I don't see, when we think about how patients are treated, I don't think we're going to take too many of our normal intensive patients and immediately throw them into a paradigm to lower intraocular pressure by 30% using any means necessary. I'm certainly not throwing these normal intensive cases into trabeculectomies. So I think, to me, what it tells me is identify the patients who are most apt to progress, treat them aggressively, but aggressively using medicine or SLT or MIGS procedures, which we now have available to us. Probably not trabeculectomy unless they have very progressive disease. And of course, we move on to TRABs, but recognize that some of these patients probably can even be followed without treatment at all. And I know that's heresy to say that we have glaucoma patients who we shouldn't treat. But I think some of these normotensive cases who might have, a single wedge defect or something like that and nothing else, and it's not threatening fixation, we might be able to follow them without treatment for a period of time until we see that they are progressing or they're rapidly progressing or they're threatening fixation. Again, heresy to some degree, but I think there are some of these patients who we probably, our treatment can be just careful watching. And of course, those patients, we want to know those patients. I would never do that with somebody who I'm just starting with. I want to know, I want to get to, I want to be past the courtship period and into the marriage period with that patient and know that they show up and they understand. And I think we all should have that in our glaucoma patients. I never want to treat on the first visit unless the pressure is, through the roof and they have advanced disease. But in the majority of cases, you're usually going to see them 3 or 4 times before you start treatment to get a baseline IOP, baseline field, baseline OCT.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
The All Eyes Visual VRP is a portable vision testing platform that includes visual fields, acuity, color vision testing, pupillometry, and extraocular motility. The visual leverages virtual reality, artificial intelligence, and augmented technologies to enable eye care providers to test for and monitor common eye diseases. Visit alleyes.com for more information. Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.